Well, welcome everybody to this session of IDW. It's really great to see you all here in person, and I hear there are people online as well, so welcome to those of you online. There is a chat feature for this session, so if you have questions, please add them as we go along, and we can talk about them in our discussion section at the end. And for those of you in the room, let's have a great discussion. But first of all, welcome. My name is Nicole Pratt. I'm Professor of Biostats and Pharmacoepi at the University of South Australia. It's my pleasure today to tell you about some exciting news and developments we've had in the realm of real-world evidence, and what we're trying to do there to unlock the value of that data that we have here in Australia to improve healthcare. So I'll talk to you about the Australian Health Data Evidence Network, or ARDEN for short. I may switch between AHDEN and ARDEN. I'm trying to get my pronunciation correct. But what we're really trying to do here is build a national data infrastructure for standardised federated health data research. And my wonderful team will go through different sections here. So Graeme Hart, Roger Ward and Jodie Austin. So I'll introduce them as we go along. But first, I'd just like to acknowledge that we're standing here today on I don't know the lands that we're standing on. How do we say it? Okay, I can't say that. But I'm from South Australia, from Adelaide. I'm from the lands of the Kaurna people of the Adelaide Plains, and I pay my respects to elders past, present and emerging. Okay, first, some other acknowledgements. I really want to acknowledge the ARDC, who have been fundamental in the research that we will present to you today. They've really gotten behind this research and are great advocates for the work we're doing. So thank you very much to the ARDC and NICRIS. So, the vision and mission of ARDEN. As we all know, Australia's healthcare system generates a huge amount of data, but a lot of that data is fragmented. It's in different incompatible systems, often very diverse and quite different to each other. And that really hinders interoperability amongst those data. So we have a lot of data, but we're not always able to access it efficiently. This really limits our nation's capacity for large-scale research, and large-scale research, timely research, to really improve healthcare and healthcare policy. So in the Australian context, us at the University of South Australia and the ARDC and partners across Australia in many of the states, including universities and the healthcare sector and policy, have established this Australian Health Data Evidence Network. So what I've got up here, it's a bit small for you, but across Australia, I think we all know that electronic healthcare records that are maintained by the states for our hospital networks are quite heterogeneous. They're very different systems across the different states. This is probably not even updated where they are now. There's lots of change in those states as well. So the electronic medical record systems do vary quite a lot. So that means we have some issues that we have to deal with, and there has been a lot of change in this policy and environment over time. So what we have is a data system that's fragmented, it's inconsistently stored, managed, and sometimes the quality is unknown. Right? We aren't able to feasibly look at that data and understand its quality and how that may impact on the evidence that we generate. What we want is data that's harmonised to a consistent format to ensure consistency across the states, right? So we really want to be able to understand what we're doing, and we only really want to do it once. The research itself on those data are uncoordinated and often isolated. So different analysts in the states are doing different things. What we want is a coordinated collaborative network of studies that only require one file across the states. And that data is co-designed, or the evidence we want is co-designed with clinicians, researchers, data custodians and decision makers, right? Asking everyone to come to the table together to generate the evidence that we need. And because of that, we also need to build skills. We need to have cross-disciplinary researchers and clinicians to really upskill our community so that we can make the best value out of those data sets. Right now, those skills are limited. Researchers have access to their own data, but we haven't got, a groundswell of researchers who are skilled in unlocking that value. We need the skilled workforce so that we can mobilise to generate robust and reliable evidence. But we also need people to be data literate. We need a data literate community, not only those who use that data, but we need to have data literacy in terms of who consumes that evidence and understand its quality. In terms of services, we have bespoke once-off solutions, and they quickly become obsolete. I mean, if anybody hears any of the work here today, it's likely to move quite quickly and become obsolete. So we need to have solutions that will persist into the future. We need shared resources. We haven't got enough people in Australia to do this on our own. We must share our resources and generate reusable solutions that are systematically update and reduce research waste. Okay, and this is one of my key ambitions in life, is to reduce research waste. We need to work together and we need to unlock the value as quickly as we can. In terms of policy, there's no coherence in data access and data governance, and this means that we potentially have identified data duplicated in multiple places. Okay, there's no need for that in research. We need to have data secure in one environment, and we need to take the researchers to the data. We don't need to be sending data across the different jurisdictions or extracting data. Data stays in place, and we want researchers to go to that data. Right, but first we need to think about, what does healthcare data look like? So what I've got up here is a patient journey when they go through the healthcare system. What we have is bits of information about a patient, and that's usually across different data systems, across different data silos, but it contains all of the records that happen to a patient across their healthcare journey. We have conditions, we have drugs, procedures, measurements, a lot of different pieces of information, but often segregated. Those data, while they're different across the journey of a patient, they're also differently stored in the different data sets. Okay, so you might think about this as source 1 might be South Australia, source 2 might be Western Australia, source 3 might be Queensland. Each of those data sets have a very different structure and a very different format. So if we want to write any analytical code, we have to write a bespoke data analysis. That can be kind of analogised to a travel adapter and the concept of different electric systems across the world. We have an iron. That iron only works in Australia. If we want to go and use that same iron in Japan, we need to take with us a travel adapter, plug it in, and our iron still stays an iron. It still works as intended. And that's really the concept we're talking about today. We want to plug our iron, which is our analytics, into the different sockets across the world. So this is the concept of a common data model. We take the different structures across the world, across the different data sets, across the different states in Australia, and we transform that into a common data model, a common format for storing our data. But we don't stop there. We also translate the data, or the data within those data structures, into a common representation or a common vocabulary. So it's like, translating languages across the world. We take what's in the data and we translate it to a common representation. So now we have this kind of setup. We have all of our data sets transferred to a common structure and a common language, and now we have the ability to plug in any of our electrical appliances into this socket, and they will work regardless of where you are in the world and regardless of the language that you speak or the language that your data are stored in. And that's the concept of the OMOP Common Data Model, which we'll hear about a bit more in Graeme's talk. So, can we do this in Australia? Can we harmonise all of our data sets into a common data model to improve healthcare? And that's the focus of the Australian Health Data Evidence Network. What we're trying to do here is build that system so that our iron in South Australia will work in Queensland, and we only need to build one iron. So AHDEN's mission is to build a nationally coordinated infrastructure that supports the transformation of hospital-based electronic medical records into the OMOP Common Data Map format. The OMOP CDM is an open source, internationally recognised data standard that enables consistent, efficient structuring of observational health data across multiple different sources. And we're talking just about hospitals here, but that's, only one part of the story. Primary healthcare systems can be translated into this model. Disease registries can be translated into the model. Whatever clinical data you have is likely to be able to be transferred into the OMOP Common Data Model. And by transforming diverse local healthcare data into this CDM, AHDEN will enable researchers to apply a common suite of analytic tools and methods to gain insights more efficiently, and this will really enhance their reproducibility. We know exactly what the data analytic file looks like, we know exactly what we're going to get, and we apply that exact same methodology across those different data sources, and that really reduces some of the heterogeneity we have in analysis of data. Importantly, and we'll talk about this a bit more as well, this approach really does highlight a way of producing research without compromising data security and privacy. And I mentioned earlier that this approach means that all of the data are maintained behind the firewall within the system, and all that gets taken to the data is the analytic code, and all that is extracted from that are the summary data and the statistics. So there really is no need for researchers or other people to look at the data itself, only those with appropriate access. So ultimately, AHDEN will strengthen national research capacity, foster data-driven health policy, and unlock the full potential of real-world data for improving population health. So this is what AHDEN looks like. So we have 5 integrated pillars. The first is our data pillar, and I talked to you about that. We're going to translate or assist in the translation of data within the state boundaries to the OMOP Common Data Model. And once we have those data in a standardised format, we can then have a network of researchers that can interrogate those data sets in a secure and harmonised way. Across both of those pillars, we have capacity building opportunities. So we're really trying to upskill the Australian workforce in terms of the data management itself, and also in research skills to make the most of those data. And I talked a little bit about federated services. So these are reusable solutions to standard questions across Australia. There'll be a suite of tools that researchers will be able to reuse and change their query, say from heart failure to heart attack, with just a small tweak of the code, and that resource will be available. And of course, what we're trying to do is advocate for this approach and really influence policy and how we generate this information from the data sets that we have across Australia. So again, I've talked about this. Just lastly, how it works. An investigator in a hospital doesn't really have access to the individual patient level data of the hospital. What they have access to is a way of producing an analytic code that's submitted to the institution, and the analysis is executed, and then the hospital then only shares the results of that query. That's all we need then to understand our question across those different sites. So that's a quick overview. What we're going to do now is get into our individual presentations, and those presentations will really walk you through the journey of the OMOP Common Data Model. Talk a little bit about the technical foundation of the OMOP Common Data Model. We'll talk about approaches to governance and security of this type of approach. and then gain some practical insights from Queensland about how they've actually gone with implementing this process in their hospital-based EMR system, and I'm really excited to hear the developments there. And lastly, we'll bring it all back together and talk a bit about the clinical use cases here. What are we actually trying to do? We're not just building infrastructure for the sake of building infrastructure. We're building infrastructure so that we can generate the evidence that healthcare system needs here in Australia to improve, okay, and create value and improve patient care. So I'll finish up with some examples about what's happened internationally and what we can do here if we use this approach. So I'll pass now over to Graeme Hart, and we'll keep moving. Right.
Thanks, Nicole. Hi, everybody. My name's Graeme. I'm an ex-intensive care specialist from the Austin Hospital in Melbourne, where I worked for 4 decades or so, and I've recently retired from clinical practice and keeping myself amused and hopefully intellectually active, helping out with this project, which is quite dear to me because I worked for many years at the Intensive Care Society's National Patient Audit Program and set up the national database and all that stuff, and I've been heavily involved with electronic medical records in both Victoria and across the Austin, as well as Chief Medical Information Officer. So I bring those various skill sets to bear is quite important. And I guess one of the first questions I would actually like to raise for this audience is how many of you have an exposure to health data, because some of the things we'll be talking about might be a little bit hard for understanding for those who are not in the health domain. So, okay, great. So maybe a third or a half. So if you'll bear with me, I'll just try to explain some of the things in a little bit more detail so that everybody has some understanding. I don't want to leave people in the dark. It's easy enough as it is. So OMOP stands for the Observational Medical Outcomes Partnership Common Data Model. So that's why it's easy to say OMOP and the CDM. It's a standardised data schema that was developed probably 30 years ago in the United States, partly around pharmaceutical post-marketing surveillance. And over the years since then, it's grown up to an international network which probably captures data on about 1 billion people around the world. So we'll come to show you some of that a little bit later. The concept behind it is that because electronic medical record data is captured in a huge variety of proprietary and vendor-specific systems, all of which use different data models, all of which have many, many, many tables, it's really hard for analysts to extract the data and bring it into research-ready data sets without a huge amount of hard work and a cost for every clinical query that is raised against that data. So the value of setting up something like this is that we have a reusable resource which is standardised and which simplifies both the ethical management, the data governance, the query structures, and the speed at which we can actually get data out. So we can have this common representation using specific and reusable international standard terminologies such as SNOMED-CT, the LOINC for pathology data, ICD-10 in its various forms across the coded data sets. And so we can bring a huge realm of already extant information and technology and data systems in place, and we plug and play this into the new data model, which contains between 5 and 7 tables, depending on how you look at the structure. So it becomes a much simpler process to manage. And we can then perform systematic analyses on this data. And one of the things that we often hear is that data captured as part of a natural care process often has deficiencies in it. The intern might have forgotten to write the diagnosis code, or the problem list may not be incomplete. So part of what we need to do is to make sure that the data we have is research ready, complete as we can make it, but we need to accept that data captured at point of care is often not as good as research collated data, and so the systems and statistics and processes that we use have to be set up to manage that uncertainty. And so the international community, which has been part of the OMOP world, has set up some incredibly robust standardised methodologies in order to cope with the complexities of some of this data captured at source. So we can use it in an individual institution. We can map data across multiple different vendor systems and share the queries, as Nicole has said. We can use it for pharmacovigilance or for outcomes methodologies on implantable devices, a whole range of vaccination safety, a whole range of parameters. And then we can use it in this multi-institutional research environment where we have this federated system of compliant data and aligned researchers. And Atlas is the web GUI for the clinical researchers, enable them to simplify a lot of these complex statistics so that they can actually use it in a way which is meaningful to them and which helps us to get robust responses, because the Atlas model incorporates a lot of the standardised methodologies that have been developed by the community. And just because this is a data science talk, we have to have some data science in it. So here, this is a sort of a very high-level structure of what the ODYSSEY Common Data Model looks like. It's all related around the person, the location, the episode, the treatments that are provided, the diagnoses that are made, and the outcomes which occur over a period of time. And Nicole showed you that slide looking at an individual patient journey across the health sector. One of the additional complexities we have in Australia, of course, is that there are public, private, multi-jurisdictional, GP, health service, all of these different things. So we've got lots and lots and lots of potential gaps in the data, and we need to make sure that the studies we design cope with that, and we probably need to set up some federated arrangements whereby some of those deficiencies can be ameliorated. And is it okay to say that we're in discussions with the Institute for Health and Welfare and other things to set up some pilot projects where some of that aggregated de-identified data may also be OMOP'd, and which would also then enable us to do some of these international studies as well. So we can look at it to identify patient populations and look at the healthcare interventions they've had, the characterisation of the populations of patients which received these and which then have an outcome attached to them. And then once we have that complex and robust methodology on large numbers of patients, we can look at the statistical modelling and start to look at individual patient predispositions to certain disease entities or treatment outcomes. The OMOP dataset relies heavily on these concepts, and there are many hundreds of thousands of concepts. I'm sorry, you probably can't read that very well, but essentially the metadata on the table on the left-hand side of the screen there shows that there's a specific concept ID which is is the primary key for that particular condition. The concept name in this example is called atrial fibrillation. The condition is called the domain ID is a condition. The vocabulary that we're using in this instance is a SNOMED CT term for atrial fibrillation, the number of which is 494360004, which you don't need to remember. And then we can look at what are the dates under which that condition occurred for this patient, and which helps up to set the data analytics templates behind. And the stuff on the right you can't see, but it basically just shows how many concepts there are in certain of these domains. And so in the methodology that we're advocating here, we can set up a study cohort. So a cohort basically just defines a group of people for whom a specific set of conditions exists. And that condition could be, for example, the people over the age of 50 who may be male, who've had no episode of hypertension documented prior to a certain onset date, who now have a drug that's given to them for the primary treatment of hypertension, and we want to look at that cohort of patients and see what happened to them in the next 5 years as the data is represented in the data set of interest at that hospital. And so we can look and then see, well, did that patient get a complication of hypertension, such as a stroke or a myocardial infarction? Did they develop acute kidney injury? Was it associated with diabetes? We can look at a whole range of parameters over the course period of this person's illness and see whether the primary treatment was sufficient, whether they had treatments added, when. There's a whole range of things that the data set is designed to facilitate in terms of those sorts of analytics. And then the researcher graphic user interface. This is a screenshot of the atlas. It's a bit hard to see, I'm afraid. But it basically allows us to define the data sets we wish to use, the terminology sets we wish to use, define our cohort, look at the interventions, look at the outcomes of those interventions over time, and then to conduct a number of validated statistical assessments of that cohort of patients, which could number between 10 or 20 or hundreds of thousands. So what is it about OMOP that makes it different? Well, we've talked about some of these things in terms of the ability for it to take abstract, complex data sets and convert them to a much simpler form. But also, I think Nicole's already mentioned the fact that because data is not moving from the owner of that data, the health service of interest, then we can actually do a lot of things around the simplification of ethics and data governance. And one of the things that we're hoping to achieve is to reduce the amount of time it takes for a researcher to get access to data that they want to study. So at the moment, if I, as a researcher, go to any one of the data aggregating organisations that have been set up in our states, the Victorian Agency for Health Information or the Institute for Health and Welfare, you know, at worst case scenario, it's going to cost you hundreds of thousands of dollars and it's going to take 2 years to get the data. So some of the complexity around getting these data and the timelines involved mean that the research question's done and dusted by the time you actually get the information you want to share. So we are hoping that we'll be able to streamline the approach to ethics and governance because of the specific characteristics of the OMOP data sets, whilst recognising that each jurisdiction has its own obligations and requirements for how they manage the data with which they've been entrusted. And then we hope that we can actually get rapid access to that data, particularly, for example, in the instance of another pandemic. So, for example, during the H1N1 influenza pandemic and in COVID, these data sets and these organisations were able to rapidly extract data around propensity for disease, severity, survival, because the data was coming out not quite in real time, but certainly within weeks or months of the thing rather than years. And so we can actually look at that. And this graph, all the blue dots represented collaborators within the ODYSSEY network. You can see that there are something like 4,294 collaborators listed as of 2025 in 83 countries, 21 time zones, and as they say, one community. And there were probably 1 billion odd patients represented within this data, within this organisation. What I'm going to do is just briefly show you a number of slides which Nicole will possibly, and some of the other speakers might also demonstrate in more detail, but I'm just going to briefly just show where some of the information that you might wish to follow up on lives. Now, on the odyssey.org website and on YouTube, there are large numbers of lectures recorded, and so you can see here some of the speakers that we had in the ODYSSEY Asia Pacific conference a year or so back. And this just shows the way in which each of those individual patient journeys with conditions, drugs, procedures and measurements on a specific timeline can all be date and time stamped to an initiation period, and then all of the people within that cohort can actually have their same patient journey documented in a way that's meaningful to the statistical analysis. And this fella here up in the top right corner is a guy called Patrick Ryan, who's one of the originators of the ODYSSEY program many years ago. And he's a very powerful speaker, and I recommend that you actually hook online and see some of his work. But he's basically here emphasising that the types of evidence desired really fall into three major groups of classification: clinical characterisation, population-level effect estimation, and patient-level prediction, all of which have got their own specific methodologies attached. So once again, using the clinical characterisation of what actually happened to these people, we can go through patient levels and population level effects, and using these standardised vocabularies, the data network and the standardised open source tools, then we can get rapid assessment of the outcomes that we are trying to observe. And Nicole's going to show this in a bit more detail later, but essentially what they've done is they've set up a series of standardised methodologies and questions. So, for example, and you can't read this, so I'll read it for you. In a clinical characterisation of disease natural history, the structure is, amongst patients who are diagnosed with insert your favourite disease, what are the patient's characteristics from their medical history? So in this example, we could substitute from our favourite disease to rheumatoid arthritis. So amongst patients with rheumatoid arthritis, describe the age, gender propensities, occupational information and health service utilisation associated with that disease over a period of 10 years from the first diagnosis. So these are the sorts of questions that sort of question terminology will enable us to establish. And I'm not going into all of the rest of them because that's going to be done in a bit more detail. So the journey to evidence is one of the areas which Nicole's also going to talk to more, so I'm not going to reiterate this here. And one of the things we're clearly keen to do, particularly when we talk to clinical trials researchers and others who've got such heavily defined data sets, strict protocols, highly defined cohorts for comparison, preordained numbers needed to treat and statistical measures usually published in advance, we need to make sure that the way we do business is equally robust, but it will be different. So the desired attributes for reliable evidence, and Patrick's talk is going to be much more erudite than my quick go through here, but we need to make sure it's repeatable, reproducible, replicable, generalisable, robust and calibrated. And the questions can be the same, the researchers can be different, the data should be identical or very similar, the analyses we perform, depending upon the circumstance, might be identical or very similar, and the results we get should be predictable as to be either, depending on which of those models we're looking at. So it's really important that if we establish these cohorts, that we actually can ensure that the data we get from Queensland is the same or understandably different to what we get in Victoria. The only way we can compare these things is to actually run the same analytics on the same data, the same question, and then compare the results. And hopefully we should get, if it's a treatment-independent condition, we should get the same result. But if there are differences in, for example, the time to first treatment, which is jurisdictional or hospital-based, we might get different answers because the data's not quite the same. And the models need to be set up to understand those differences. It's impossible to read that, I'm sorry. But basically, I just wanted to show you how many studies there are and how you actually work it out. So on the Odyssey website, they list all the current Odyssey network studies, and people who have an Odyssey data set can actually opt in, or even if they don't, if they wish to collaborate as a clinical researcher or a data science expert, they might wish to collaborate with some of these people and you'd be welcomed into the network. There are over 5,000 OMOP citing publications on Google Scholar as of the 12th of May 2025. So you can see there's a huge international community of practice which is using this technology. So we're not the first, certainly. We won't be the last, hopefully. But at least there's a very big cohort of people who've done the methods, the transformations, the research, on whom we can piggyback the work that ARDEN's going to do. So in summary, OMOP CDM is a person-centric data set. It's de-identified. We share queries, not data. It's mapped from commercial EMRs and other data systems using standardised terminologies which are well understood within the health data community. It uses validated analytic tools done by statisticians and data science who are much smarter than me. We can aggregate our results between one and many different organisations, and we've got capacity for rapid research into new health threats in an international community of practice which has agreements on everything from data sets to publication protocols and governance. So we welcome you if you wish to participate in any of this stuff. But thank you very much.
Thank you, Graeme. That was excellent. My name's Roger Ward. I'm a solutions architect with the ARDC. I've worked with Nicole for around 6 years. Before I joined the ARDC, I worked at the University of Melbourne, and I actually worked with EMR data, routinely collected EMR data that we used for research. And I've also worked with Graeme for a number of years. So it's nice to see everybody here today. Now, this is all very well what Graeme and Nicole talked about. They talked about using this data and asking clinical questions, research questions. But what about the governance and the data privacy for this patient data? That's what I'm going to talk about today. Okay, so this is ARDEN is a project that's been instituted by the ARDC. It started in June this year, so it's a very new project. We've been going for about 3 months. And we've got 5 work packages. Work package 1 is data asset development. Work package 2 is research coordination. That's these use cases that Nicole talks about. So developing the questions that we want to ask of the data. Work package 3 is about training people. So we have to train the data scientists who do the conversions, and we have to train the clinicians and the researchers like Graeme who want to use the data. Work package 4 is all about federation services. So as Nicole said, we want to be able to share the knowledge. We want to be able to share the code. We want to be able to share the mappings and the ETL codes. So that's what federation services is. Finally, work package 5 is advocacy. And this is really important because we've got to go out and talk to government. We've got to talk to the federal government, the state governments, the hospitals, patient groups. So advocacy is key. Advocacy is key. Now, just in relation to governance, there's 2 work packages where governance is really important. And the first one is work package 1. Because it's pointless developing these data sets, doing these conversions, unless there is governance in place so researchers can access the data. So we're putting data governance front and center of everything that we're doing. So this has a very high priority. In fact, I would say it's the most high priority item that we're working on in ARDEN, having data governance in place so researchers can actually use the data. And also work package 5 touches on data governance as well, because as Graeme intimated, we're talking with the federal government about their data sets. We're talking to state governments about their data sets. Part of the ARDEN programme is Queensland, which you'll hear from Jodie in a second about, and also South Australia. So the Queensland and South Australian government data sets are in scope for ARDEN. So it's really important that we get the data governance correct. So effective data governance for OMOP. The key principle here is we don't exist in a vacuum. The hospitals and the health authorities already have good data governance in place. They've been doing this for years. They've had these electronic medical record systems for many years. Austin Health, for instance, in Victoria, I think your system... 2013, yeah. So they've been operating this system for the last 12 years, so they know exactly what they're doing with data governance. So what we've got to do is work in with existing data governance procedures that are already in the hospitals. And what we aim to do is streamline access and approvals for researchers who want to gain access to the data. We respect existing local governance authorities and data custodians. But our aim should be for faster access to low-risk, pre-approved data requests that can be fulfilled quickly. Because, as Graeme said, in the past, if people wanted to do research on routinely collected clinical information, it often took years. I think 2 years is pretty generous. It was more like 3 or 4 years to get a study done, and we want to improve that. So, in the ideal world, each jurisdiction should establish a clear and consistent mechanism for researchers to access research data. Because as I've said, it's no use having these data sets if no one can access them. The access process should be streamlined wherever possible, making it as easy as possible for researchers to access the data. while respecting the local governance and the patients and the data custodians. Ideally, pre-approved ethics and data custodian permission should be in place to enable timely access to low-risk studies. And what we're aiming for in ARDEN, we've got 5 nodes across Australia. We're aiming for coordinated oversight. So wherever possible, we're aiming to coordinate this and have a standardised approach across Australia, because people want to do these network studies. They want to write some code in Victoria and then be able to run it nationwide. So we want coordinated oversight of data governance in ARDEN. Okay, so let's talk about patient privacy with the OMOP distributed model. Firstly, it's privacy by design. There's local control and aggregation. The operational data is untouched. So the EMR data that Graeme talked about, we don't touch the EMR data, but we work on a transformed version of that EMR data. And wherever possible, we remove any PII, which is personally identifiable information, from that data. As Graeme and Nicole have both mentioned, we've got a distributed network model. So OMOP enables you to write code in Victoria and then distribute it to the other nodes in Queensland, South Australia, and run the code in the local nodes. And also, it allows that code to be run in London, for instance, where they've got data sets, or Barcelona. So it's this distributed network model that's so powerful with OMOP. Okay, safe data. So the analysis, as I've said, are executed locally and only aggregated results are shared, preventing movement of sensitive patient data. So the data stays exactly where it is. The data is de-identified. As I said, we leave the PII behind. So we leave the names, addresses, postcodes, identifying material behind. Risk mitigation. Existing security controls in hospitals apply to the data. I'll show you this diagrammatically. So what we've got here is a representation of how OMOP works. So on the left here, we've got the production EMR system. That's the green cylinder. And that's the clinical layer, I call it. And then typically what happens in hospitals and health authorities, they take a copy of that data into a data warehouse. So that's an offline copy of the data. So what that means is the production EMR data isn't touched, it's the offline data warehouse data that's touched. And when I say it's touched, it's converted into the OMOP common data model with a transformation process. And I call this the research layer. So the data warehouse, and on the right, the common data model. And the dotted line around all these databases, that's to mark the jurisdiction of the hospital or health authority, meaning that the data never leaves that jurisdiction. In effect, the data warehouse is probably a SQL database, and the OMOP common data model is also a SQL database. And they will live in the same environment in the hospitals. So the controls are in place in the hospitals, the security controls apply to the data warehouse data and the OMOP common data. So we're leveraging existing cybersecurity and controls that already exist in hospitals. Steve Jobs was a bit of a hero of mine, and he made this quote, simplicity is the ultimate sophistication. And you're probably thinking, well, why is this guy quoting Steve Jobs? Well, I just wanted to talk to you about EMR systems. On the left, I've got a diagram representing Cerner or Epic. Now, these are the EMR systems. Now, what you're looking at there's probably 50 or 60 tables there. The reality is, Cerner has 5,500 tables to serve up that patient record to the doctor or nurse on the ward. They're immensely complicated things. And trying to do research based on EMR data is nightmarish. But what the common data model does is it allows for simple, structured data. So on the right, this is the OMOP common data model. There's 12 fundamental tables, and it's based around the person. So we're interested in diagnosis, medication, procedures, and observations. So what I'm trying to convey here is we go from something that's very complex and organic, and we condense it down into simple, structured data, just taking out what we need to answer our research questions. And another thing to emphasize here with simplicity, it's SQL. So it's just a SQL database. It's beautifully simple as the OMOP common data model. SQL's been with us since the 1970s. It's very old technology, it's very simple technology, it's very well understood in hospital IT departments. So there's nothing revolutionary here. It's just a simple application of existing technology. But the power is, once we've got it in a common data model, we're making the data ready for AI as well. So this is a really exciting time to be working in this field. When I started on this, it was 2019, and we talked about machine learning and AI, but it was in a very sort of abstract form. Now here in 2025, we're at the stage where we can potentially use these AI models on this data. And as Graeme said, the OMOP common data model, there's around 1 billion patient records on it already. It's widely used around the world. So we've got the potential for enormous studies to be done on this patient data. And it's really good for rare diseases. So if you've got a rare disease in Australia, and the numbers are too low to really make anything meaningful results, you can multiply your data by connecting it with data in other countries. So this is the power of the common data model. So just to summarise, we start with the patient data in the EMR system, and the two big EMRs in Australia are Cerner and Epic. We anonymise that data, we take it over into the OMOP common data model. This enhances the privacy of that data. And then we do federated analytics, which is the use cases that we talked about running, the network studies that Nicole talked about. And this also leads to enhanced privacy because the data stays within the hospital and the code goes to the data, so the analysis code goes to the data. Okay, so that's my talk on governance and data privacy. Now I'd like to hand to Dr. Jodie Austin from Queensland Health and the University of Queensland, and she's going to talk to you about what's happening in Queensland.
Thank you. So, as Roger said, my name's Jodie. I'm the Clinical Informatics Director for the Smart Hub. So we're a team that sit within the University of Queensland, but we also hold conjoint positions. So our team cross two organisations, UQ and eHealth Queensland or Queensland Health. So we really try and bridge that gap between academia and the healthcare system. But I'll talk to you in a bit of a detail about the team on some slides to come. I just wanted to, set the scene first before we get going. So in Queensland, we've had the steady rollout of an integrated electronic medical record, what we call the IEMR. And this is a single instance, a single statewide instance. So if you're logging into the IEMR up in Cairns, it's exactly the same look and feel as if you're down here in one of the metro hospitals in Brisbane. I don't even think this slide does it justice now. They keep rolling out at a phenomenal rate. So we're up to over 50 hospital sites that are live with the IEMR. And we've also got correctional centres and community centres that are also going live with the same instance as well. So just for those who aren't local, just to have, an understanding of the sheer size or the geographical expanse of this state. So we cover an enormous amount of land mass in Queensland. So that statewide IEMR traverses a huge geographical distance, all the way from up in the tropics of the far north Queensland, all the way down to, here in the metro facilities of Brisbane. So to equate that, it's about the same as if you were travelling, it's equidistance from, say, Paris to Poland is the type of coverage that we've got in this state alone. So why are we doing this? At the Queensland Digital Health Centre in UQ, where we're based, we really are trying to facilitate or streamline this access to real-world data for healthcare research. So this isn't a diagram that I've developed. I have got the citation there on the slide, but it really does make the point that what we're trying to do is harness this real-world data that we're now generating so routinely, as I showed you with all those electronic medical records that are popping up. All of a sudden, this healthcare data is it's digitised and it's easy for us to tap into. So we need to be able to harness that real-world data that routinely was just being written on paper charts and then filed away in a HIMSS department, never to be seen again. So what we're trying to do is be able to tap into that real-world data to generate real-world evidence. So in healthcare, generally the gold standard for healthcare research is your randomised controlled trials or your RCTs. We're not trying to replace RCTs, so you're still always going to need RCTs to be able to look at efficacy of interventions, whether it's medications or procedures, for example. You still want to do those RCTs in those controlled environments before you let loose on an intervention with your general public. But what we're trying to do is complement that with this real-world data so that you can then look for longitudinal data over time for the effectiveness of when you put those interventions in real-life situations. So it's going to get messy because all of a sudden your patients have got the comorbidities and all those things that they've excluded in RCTs, but all of a sudden you can have a look at how effective those interventions are in real life over time. So the way we've tried to look at it within Queensland, and this was put together by our team, is how do we best summarise our approach to data access for modern day health research? So we are still always going to need to tap into production level data, which is that top right quadrant, but obviously that's that high disclosure risk for patients. But we're trying to then look at some of these more novel methods that we can implement to be able to tap into that real world data for healthcare research, such as federated learning, which we've already kind of touched upon. The team are also looking at how can we generate synthesised data. So we're doing a project on synthetic EMR data to help improve access to healthcare data. But a lot of these are all relying on this foundational work of mapping to a common data model first, and that's where OMOP comes in. So for us in Queensland, what's the need? Well, it goes without saying, we want to be able to collaborate further afield, so nationally and internationally, and healthcare is just riddled with these disparate data sets, both clinical and administrative, so we really need to try and pull these together so that they start talking the same language. We want to be able to access that large real-world data like I showed you on that diagram, but minimise patient disclosure risk. And we also want to reduce that burden on our data engineers and our informaticians for running bespoke research data extracts as they come through. So where we're at the moment within Queensland, we have mapped our local statewide IMR to the OMOP Common Data Model within a non-production environment, so we called it our train domain. We're in the process now of that conversion from mapping from the train domain, we want to map into the production environment within Queensland Health. So the process that we undertook, and I've just got some scenarios, I'm not going through the whole, every piece, but for example, when we were looking to map or do the concept mapping for very clinical data, for example, medications, pathology results, we wanted to make sure that we had subject matter experts that were involved in that concept mapping to make sure we were doing it appropriately. So for our medication mapping, for example, we had medical students that we brought on board and we're helping with that conversion from our local IMR data, which was we use Cerner as our EMR vendor, or Oracle Health. So it's using Molten vocabulary for its medications, which is a non-standard form. So we needed to get our medical students to help with conversion to that standardised RX norm terminology before we converted it into the OMOP concept IDs. In terms of the process of mapping the IMR to OMOP, so there are some scenarios where, in this example, if a patient's admitted, comes in for a visit, their visit details will be stored on one table. That will be the encounter table, for example. If that patient is then converted from, say, an emergency encounter through to an inpatient, that just converts, but it still sits on the encounter table. So if you were going to do a research project and you wanted to understand for all the different ED encounters, the different diagnoses, for example, that came along with it, this all moves into different data tables in the back end of Cerner. So you actually then need to, we've only got one visit occurrence table within OMOP, but we're actually needing to map multiple tables from within these visit tables across into the one OMOP. So we've got many to one happening in this scenario, versus conversely, we can have, so for example, our clinical event table within Cerner has a huge amount of data for the patient that's stored. It might be their medication administrations or their observations or their pathology results, all landing on that one clinical event table. But then in OMOP, we've got measurements, we've got observations. So it's that understanding and teasing out and extracting and putting them in the appropriate tables, the OMOP tables, and doing the appropriate concept mapping. So in this scenario, you've got one to many. And lastly, in the Cerner EMR, for example, we would keep our allergy and our allergic reaction information stored together. But in OMOP, we've got our allergies stored in observation and we've got our allergic reactions stored in condition occurrence. So then we need to use the fact relationship table in OMOP to tie these all together. So this has probably already been covered, but just to say, you know, the real highlight, I guess, for using this OMOP common data model is this person-centric model. And as I was talking about previously, we have that real ability to then look at longitudinal data analysis. I won't talk too much about this. We've got data engineers on my team, but they were using a lot of these tools for their validation and quality assurance in terms of, you know, once they were making sure that they had that data completedness once they'd gone through that process. So the future for us, and we are looking, we've got some projects on the go at the moment where we are looking to map not just the statewide EMR to the OMOP common data model, but there are other organisations doing the same, so we can look at this federated learning approach using machine learning models and sending that model in and then just pulling the data out. And as I've said before, we're really, you know, focused on doing this patient-centred research. So how are we going about doing it? So the way we've proposed in Queensland is to set up, and that's the team that I work within and lead, is the Smart Hub. So originally we were a SMART project, and the concept behind this is, can we bring the university sector closer to the hospital and healthcare sector so that we can streamline access to healthcare data focused on research? And so that's what we did. It took a number of years with legal teams to be able to be comfortable with this concept of the same people working across a hospital and healthcare organisation and tapping into their data, and also working for a university as well, so moving through with those conjoint positions. But we did get there in the end. It took a few years. But in late 2023, our team, which is the Smart Hub, we became embedded within eHealth Queensland, within the Office of the Chief Clinical Information Office, or OCIO. So our team co-locate. We do spend part of our week with eHealth Queensland and part of our week with the University of Queensland. And when we are over there in Queensland Health, we do operate strictly under their policies and procedures. And we report directly into the OCIO's line management. So this is our team. I guess what I wanted to emphasise here is that we are a real mix between clinical and technical. I'm from a clinical background, so myself, Tara and Josh are all clinicians by background, whereas Reggie and Yasho are from that data engineering technical components. So our work to date, as I was saying, we've already mapped the IMR within the train domain. We did do a subset of tables, but to be fair, we did do a lot of the tables. There was only a few that we missed when we did that proof of concept work. But we're now at this point of wanting to move what we've done into the production environment. And part of the reason why we started in the train domain was because we didn't have those conjoints up and running at that point in time. Now that we've got those conjoints and our team are embedded across the two organisations, everyone's a lot more comfortable with us jumping in and doing, you know, this data conversion. So we have got the schema already established on a centralised statewide platform. We've got the 4 schemas there ready to go. We're just working through our ethics and governance. I just wanted to map out, you know, the way we're approaching this project. So we do have support from the Deputy Director General of eHealth Queensland. But they've asked us, when we went to submit this to the ethics, the HREC, the Human Research Ethics Committee, they did ask us to split our project into 2 phases. So they wanted us to go with phase 1 first, where we showed them our governance framework, what's our technical and information architecture, and what's our implementation plan. So we did that, we submitted it, we had to go away and achieve those phase 1 deliverables, which we've done. And now we've recently just submitted for our phase 2 deliverables, which I guess is, where you're really rolling your sleeves up and getting your hands on the data. So I just wanted to show you in terms of we've spent a lot of time trying to get this governance framework right, and we set up an OMOP CDM project control group, or PCG. So the purple is UQ and the blue is Queensland Health. And so I'm trying to show you there, we've really tried to make this a real cross-sector collaborative approach to this project. So we feed in, the PCG feeds into both, executives from the UQ side and from the Queensland Health side. And the PCG, we had our kickoff meeting about 2 months ago. We had a really good turnout, and we tried to make sure we had stakeholders from across the board. So we've got a lot of technical folk coming in. We've also we've got the Directors of Research Forum, which sit across, these are clinicians across all of the hospital and health services within Queensland that focus on, research, obviously. But we made sure that we had the Directors of Research Forum attending this OMOP PCG, because obviously, they're not so involved in the technical, the side of the mapping and the ETL, for example. But we really want to bring these guys along for the journey so that they understand what the utility of the OMOP CDM is at the end of the day. So we've got them sitting in on this OMOP PCG as we go through the journey together. We did also propose that we would tap into, so Queensland Health already has all these existing statewide digital working groups. So what we've proposed and what's been endorsed is, as we get going with the mapping and we've got questions, so for example, if we're mapping our medications and we have some outstanding questions that we need resolved, we will tap into that statewide digital medication working group, for example. So we're just going to tap in to existing working groups to help us with answering our questions, and then we'll feed that back up to the OMOP PCG. So in summary, we really are trying to establish some world-class infrastructure, data infrastructure here in Queensland. We're making good progress as we're converting across into that production environment. But as I say, we're really trying to emphasise this as not just a technical project, but we're trying to bring the researchers and the clinicians along for the ride as well. And absolutely, we've still got plenty to learn as we go. Thank you.
Okay, that was good fun. So hopefully now everybody has got a bit of an understanding about OMOP and about the OMOP Common Data Model, what it does, what it looks like, and how it can help facilitate the translation of data into a consistent and reliable data source. So what I thought I would do in the next 10 minutes or so, and then we'll open for some discussion, is to really address what Jodie was talking about, the clinical utility of these data. And I think I mentioned earlier, we're not just doing this for the sake of creating nice looking data sets, right? We're doing this for a purpose, to unlock the value for clinical decision making. So what I thought I would do is just quickly tell you a little bit about a use case across all of those 3 different questions that I think Graeme introduced: clinical characterisation, population level effect estimation, and person level prediction. Okay, so I'll take you through a bit of a case study. But first, I just wanted to highlight ARDC. ARDC is the international collaboration, as Graeme talked about, that really maintains the OMOP Common Data Model. And its mission is pretty simple, right? It's to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. And hopefully what you'll have heard when I said that is the empowerment is about community and it's about collaboration. Okay, ARDC is all about collaboration, and we're all working on the same goal and have the same vision of improving healthcare. So again, we're going to see this a lot. We're going to walk through this triangle and have a look at an example for each of these potential clinical questions. And I would assert that most clinical questions fall into one or other of these buckets. So we talked about this patient journey. And really, the patient journey can help us answer any of these three clinical questions. Okay, which patients choose which treatment after diagnosis? That's a clinical characterisation. Is one treatment more likely to lead to an outcome than an alternative? That's a question of population level estimation. Will I experience the outcome given my diagnosis and my treatment and who I am today? That's patient level prediction. Okay, so all of that single patient journey can answer whatever question you may think about in healthcare. And it may be just understanding disease, it may be estimating population level effects or specific effects for me as I am today. So this is really the journey we go on. We have this patient level data in our source data sets and we want reliable evidence, but there is a big journey and a complicated journey. But it can simplify down to this. We have an idea, a clinical idea. We have the data available in a standardised format. We have all of these tools available for us to do analytics. So we have packages that already do for us a cohort study or already do for us a self-controlled case series, already implement a G-boosted regression or whatever it happens to be. It's all there in federated tools. So if we have a question, we have our data set in an OMOP common data model, we have the analytical tools to analyse those data, we can then generate our results. And importantly, and we've heard this a million times, and if you walk away with anything today, it's about data security. All of that process of looking at data or analysing any data happens behind the existing firewalls within a data custodian's jurisdiction. Okay, so none of the actual raw data is ever interrogated. So there was, I think Graeme first talked about the fact that there's about 1 billion people somewhere in the world in an OMOP data set. And that equates to about 12% of the world's population. So on average, 12% of the world's population can be looked at in a OMOP analysis. And that's across many different countries in the world. The only country that doesn't have an OMOP data set at the moment is Antarctica. So. But there is one person, and I heard that he is willing to provide his clinical record for that one record to be OMOP'd. So we will have every continent. And this is just another schematic of the exact same thing. I know I'm belabouring the point, but it's really important to understand that any analysis that's done across a network is done within the privacy and ethical considerations of that data custodian. So let's have a look at the first clinical characterisation question. So what is happening? I'm not going to go through these, but here are the questions. I'm going to go back to COVID. Now, you're probably all a bit sick of COVID and heard a lot about COVID, but I think that gave us a really good insight into what is possible if we have data standardised so that we can answer these questions really rapidly if we have the need to do that. So for characterisation in COVID, what did we need? We needed to understand the underlying populations who are at risk of disease and what is the underlying rates of particular outcomes. Myocarditis was one of those outcomes that was of interest during COVID, but at the time we had no idea what the underlying rate of myocarditis was in the population, okay, in different places in the world. So we didn't really know whether an increased rate or whether there was an increased risk of myocarditis with the COVID-19 vaccinations. So one of the ways that we can utilise the Odyssey network is to just understand that. Simply characterise disease across the world. What is the background incident of rate of adverse events of special interest? And here was a study we did looking at particular COVID-19 vaccine outcomes. This study was published quite, recently, and it's got, I can't really read it from there, but 126 million people included, and this is just simply looking at rates of disease. And here they are, all the different adverse events of special interest for the COVID-19, but it's also looking at the different countries, it's looking at different age categories and different gender categories as well. And just having that information, if we had that at the very start of the COVID-19 outbreak, we may have been able to really rapidly identify if there was an increased risk with a COVID-19 vaccine. Okay, seems simple, but it's really, really, really powerful. And here's myocarditis. So we can now really understand what rate we would be expecting in the different age and gender categories and across the world as well. And you can see there's a little one there in Australia, IQVIA data set in Australia, which is just a small data set of primary care in New South Wales. So that was all we had at the time, and now there's a lot more data that we could contribute to these sorts of analyses. So let's have a look at a population level estimation, asking the question, how or why did it happen? So again, COVID-19, there was an early question when we first started to see infection that potentially patients who were taking blood pressure medicines, I should say, may have been increased risk of getting COVID-19 infection. And if they did get infected, they would have poor outcomes. So this was a really important question at the very start of COVID-19. Are patients who are taking blood pressure medicines at increased risk because of the mechanism of infection? And we can ask doctors more about exactly the mechanism, but the ACE inhibitors and the ARBs were of particular concern. So we actually worked together as a community to answer this question. Okay, and this study was conducted on over 1 million people really early in the COVID-19 outbreak. And it was really because of these types of questions that came up, right? There was unknown whether or not blood pressure medicines could raise the risk of deadly coronavirus symptoms. So that came out in March. And then just a couple of months later, the American College of Cardiology actually said, well, just wait a minute. We don't have any evidence of that. We need to understand more about this potential risk, and we need to do additional research. Okay? So we need to understand this before we stop patients taking their blood pressure medication. So fortunately, we'd done a previous study just in 2019, actually, where we looked at all treatments for blood pressure. I keep saying heart failure, but I mean blood pressure. And we had the code already written to look at outcomes of blood pressure medicines, every different type of blood pressure medicine. We had that in code. We had outcomes like heart attack, blood, all the different cardiovascular outcomes, safety events as well. So when this question came out, we were able to actually take that piece of code that we'd written previously, just change the outcome from, heart attack, and just pop in COVID-19 infection in our code. We had the code ready to go. So we were able to quickly analyse the data sets across the world that had information about the COVID-19 infection, and we were able to really quickly reassure patients and clinicians that these blood pressure medicines were not associated with an increased risk of COVID-19 infection or poor outcomes. And you can see right at the bottom, the meta-analysis there suggests that there's no increased risk with ACE inhibitors compared to other blood pressure medicines. So if we have a look at the timing of all of this, the first question came out in March, and we were able to publish those results just in 3 months. So we had that infrastructure ready to go to address a really urgent clinical need. The other thing that we do in Odyssey is we use an open science approach. So all of the artefacts that are ever generated through a network study are published. We publish all the results regardless of the result. We don't just publish our significant results. There's no publication bias. We publish everything. And all of the results are published in their own database. So you can go to this website right now and see every single bit of analysis that we produced as part of this Icarus study and any other study that has been published with the Odyssey approach. Now, patient level prediction, what will happen to me? Okay, so we can have a look at this question. What is my risk of getting COVID-19? So before we talked about looking at what's the risk at the population level in patients who have blood pressure medicine. Now I want to know, what about me? What is my risk of getting COVID-19 infection, given who I am today? And to understand that question, you need to build these prediction models or these AI models. And we can do that. I think Roger talked about the fact that now we have this structured data, we can implement these large-scale prediction models and get really good decision tools. So during the COVID-19 outbreak, we generated this seek cover prediction problem. So we take all of the information in an observation window prior to a time zero, and time zero here is just before getting your infection, and we want to know what's the outcomes of that. So I won't go through this, but we had lots of people in a large data set where we developed our model, and then we validated that model in other databases across the world. And for those of you that do prediction problems, this is really a solution that is one of those things that is really hard in this area. So we need to build models within our data sets, but we really need that external validation to understand how they work in different settings and different contexts. So we're able to deploy the model that we built in the Clinformatics data set and see how well it worked across the world in different data sets, and it worked really well, had a really high AUC. So based on all of that, we produced this online tool that clinicians could use, that patients could use to pop in their own individual characteristics and have a look at what their probability of getting COVID-19 would be, or outcomes of COVID-19. Now, you might think, well, that's not really very interesting. It's a probability. But one of the things we talked about when we developed this was how would the hospitals use this information to start thinking about forward planning in a crisis. How many people are we likely to see? How many people should we account for? What services do we need to have ready to go should we, based on the demographics of the people who we see in our hospital, how many people are we likely to encounter, and how do we plan for that? So there are quite a number of uses for tools like this for the hospitals themselves, let alone the people. So why do we need data at scale? Well, this is an old piece of research, something that the Odyssey community did together, where we looked at what are all of the different medications that are available across in the US, how many active ingredients are there, and how many outcomes of interest are there potentially, and how much do we know about that? And you can see there's not a lot of red there. If we know something about it, the particular medicine and the outcome of interest, it has a red little dot, but you can see there's lots of white space. So there's a lot of medication that is used in the world right now that is evidence-free, that is not underpinned by evidence from randomised controlled trials. And what we need to do is make better use of the data that we have in these data sets across the world to fill in those gaps, right? We need clinical trials, there's no question about that. But we need to complement those data with the data from the real world and fill in the gaps for clinicians to make more appropriate decisions for the individual patients and improve healthcare more generally. So how do we scale? I'm just going to flick through all this. So we scale just by creating standardised cohorts. And once you create a cohort of, say, heart attack, right? How do I define heart attack in my data set? I can now use that across the different analytic processes. We can clinically characterise people with heart attacks. We can use heart attack as the outcome. We can use heart attack as the definition. How do I predict heart attack? So we just build up this suite of tools that help us to identify particular concepts in healthcare, and once we have that, it's now a persisting artefact that we can use for all of our analysis as time goes on. So anytime a new, crisis comes up, we can pull on that information that we already have available to us to more rapidly address the unknown evidence need. And the way we do that is by building phenotypes. And phenotypes are really just standardising cohort definitions based on all of the data that we have. And all of this is open, so they can be verified, validated, and we can really understand how good these definitions are. And that's one of the things that ARDEN is going to do, is build up a standardised repository of phenotypes within the Australian context, so that Australian researchers know they're using validated definitions for their research, and that also helps with the heterogeneity of different approaches. And here's just an example of phenotype library that gives you a human-readable context around your definition, as well as the actual SQL code as well. And anybody can look into these things. Okay, putting that all together, we scale up analytics. We have an approach that is coordinated, that helps us to build the phenotypes, understand the things we're trying to measure, scale up our analytics, and scale up our standardised outputs. So that's where I'm going to leave it. I've just got up on the slide, again, what ARDEN is trying to do with our 5 work packages, and how we're trying to really standardise research across Australia so that we can both understand the Australian situation, but also work with our international colleagues and speak their language and participate in international research as well. Okay, so we've now got around 10 minutes for some discussion. So are there any questions from the audience? We do have a roving mic, so yep, we've got one over here, Roger. Do the panellists want to come up just in case, and we can talk into this microphone? You might have to come up here and talk into this microphone.
So hi everyone, I'm Priyanka. I work at the University of Melbourne, and for the past few years my experience has mainly been working with health research, and I have worked with this team as well before. So my question is for Roger. So in terms of delivering governance, I love that topic. So the capacity building aspect of governance, so I've been a part of projects that Graeme alluded to where you set up systems and you put in requests, and it takes a couple of years for the data to come out of the system, and by that point the research question is obsolete. So how would that sort of work when the source system, or the people who are managing the source system, whether it's Epic or Cerner, they don't have the capacity to support that research layer from governance perspective as well as data extraction perspective?
The aim of the ARDEN project is to give them that capacity, Priyanka. So I should have said, I'm from the ARDC. We're heavily investing in this program. We're putting $4.5 million into this program. And we've got co-investment from all our nodes. So we're taking governance very seriously. So we're funding them to do it. It's a key component of everything we do. Nicole's busily writing subcontracts with all our partners at the moment, and part of the subcontracts is that they have to deliver on governance as part of their contract with the University of Adelaide, and we're funding them to establish the governance. And fundamentally, it's in everybody's interest to have this governance in place. And you've seen the work that the University of Queensland and Queensland Health have put in. It's a tough process. I remember Jodie going through this, and it takes 2 or 3 years to get this governance in place. But we are funding them to do this, and we recognise the importance of it. So thanks for the question.
Thank you. Thank you for the talk, quite good, everybody. I have a question for Jodie. You have created this umbrella between UQ and Queensland Health. Now, I guess that there was a long discussion about the agreement. So you harmonize the data that you have collected through different processes in the records of the hospitals, and you make it available to UQ to perform research. And who generate the questions that the research is going to be done, or is there a kind of committee that say, well, these are the things that we need to know? That's one question. Yeah. The other is, what kind of, are these agreements exclusive for UQ to develop that research? Mm-hmm. And that means that when they have published a result, you can use that back to you? How does it work?
Yeah, okay. So we actually operate for not just the University of Queensland. So when we work on a cost recovery model, basically. So we generally work on projects that are funded. So if it's just a clinician on the ward, that's got a great question, we generally can't support unless they've got some kind of research funding behind it, and that's purely for sustainability of our team. So long as the researcher, and they don't have to come from the University of Queensland, they don't have to come from Queensland Health, they can come from we've done projects for other universities as well, but if they approach us and they've got a funded project that they're interested in, we can support them with accessing Queensland Health IMR data for that research. We still have to follow all the appropriate ethics and governance approvals that you would. But once we've got those approvals in place, then we've got our team that are designated purely to extract data for research. So we kind of bypass, traditionally those research requests, we're getting stuck with your BAU teams that are trying to do operational reporting and things like that, and they just get put to the bottom of the pile because, they're obviously just trying to keep the lights on. So we've got our team now that are purely focused on research. We're not allowed to look at anything operational. But so long as the research project coming to us, and we're, as I say, university agnostic, as long as they're coming to us and we can help them through that process of ethics and governance if they're unfamiliar with it within the Queensland Health setting. But once they've got all those approvals in place, then we can do the extraction. Yeah.
Yes, Mark Nyssen, Free University Brussels Medical Informatics Department. I was wondering if you don't think that your system introduces bias because many patients are not in hospitals. Second question, also for the operational basis, don't you think there would be a possibility to have better treatment with the 15 tables summarizing the patient for research than the 5,000 which don't get a nice summary picture of the patient?
Just to your last point, that is exactly the way that OMOP has been designed, is to take all of the mess from the original data sets and put them into a nice clean data set, right? So that if I understood your last comment, no?
Because these 15 nice tables are not accessible to the treatment, for the treatment of the patient. They are only for research.
Sorry, get it. So you mean like
so
by the clinician?
You should perhaps have the same for the treatment of the patient.
Well, I mean, there's a fuzzy line between the role of the EMR vendor and the data that comes from the EMR vendor and the data that's required for research. But I think Roger wants to.
I think it's fair to say if we were starting from scratch, it wouldn't be 5,500 tables. But these systems were started, 20 years ago, and it's a bit like a taxation system. They tend to add tables, and they don't take away the old tables. So I think there's a lot of tables that, in the ideal world, wouldn't be in there anymore.
In some of the conversations I've had with people who are in charge of IT systems in hospitals that don't yet have an electronic medical record, many of them were in fact thinking that OMOP might be a fantastic model to consolidate the information coming from a variety of different proprietary feeder systems in cardiology or the pharmacy or wherever it might be, and actually then construct a GUI that enabled people to see that consolidated information in a form of virtual EMR. So that has certainly been thought of. I'm not sure how many people have done it because it's complex to do and most of the skill sets are not here, but it is certainly something that's been discussed openly in various forums.
So I'll just quickly address that first question you had about bias very quickly. So the translation of the data to the OMOP common data model in itself does, sort of drop out dirty data, right? But you are aware of exactly what the data is because there's the data quality dashboard. You're able to uncover some of those issues and then try to rectify them, right? Without doing the process, you might not see some of that information. But there is potential for bias if there's a group of patients that don't get translated to the OMOP Common Data Model, but that's where the data quality diagnostics come in and the diagnostics of the clinical evidence itself. You wanna?
I think one of the other ramifications of the question that you asked was around continuity of the information, because Australia has a very unwieldy healthcare system. We have public, we have private, we have general practice, which is partly funded by the Commonwealth and partly funded by patients. We've got private insurers. We've got, it's a dog's breakfast really in terms of care delivery, and certainly the information continuity is quite challenging. So part of what we're currently dependent on is having continuity of the electronic medical record at point of care to update, if you like, some of the conditions that might have occurred in general practice. How often that happens with the busy interns trying to fill in a form at 3 a.m. is always a bit more challenging. Most of the medications that those patients were on at the point of entry to the hospital would be accurately recorded because the pharmacists are very robust in doing that, and the discharge medications also, and the medications and lab tests during the... So some of the gaps of continuity would be sort of partially filled, but you are very correct that some of the information that we have compared to other health systems where it's a single healthcare provider right across all the different forms of medical treatment would be perhaps more robust.
A single identifier of the patient.
Sure, but one of the areas that we've been looking at, of course, is around about the de-identification of patients. Now, it's not to say that an individual hospital or an individual care network, which has the appropriate governance and federated authorities around the ethics, could actually have some sort of encrypted linking key. And certainly that has been discussed, but it's not something that we've undertaken at this point of the cycle. There are a number of general practice data sets which are based, one of which is based at the University of Melbourne. I think Dougie's got about 3 million patients on his system from various general practices. So there is certainly the option, and the opportunity is really around how complex the governance and ethics and permissions and all that sort of stuff would be, while still ensuring that the confidentiality and privacy that the OMOP system was set up to establish is maintained.
Yeah. Thank you very much. It's been a really great, stimulating session. I'm Caroline Finch. I'm an injury epidemiologist from Edith Cowan University in Perth. And so my focus is more on population level data. But something you just said there is linked to what I wanted to ask. In my field, we use a lot of hospital service data, but a lot of effort is spent on data linkage. And so I'm wondering, there's a lot of investment infrastructure around the country in data linkage systems. How does that fit or not, or get replicated or not by what you're doing here?
Oh, that's a great question. So there, as you say, there are many data linkage data sets within each of the states. What we're hoping to do with the ARDEN project is to kickstart some of that translation of the linked data across the states. So when we talk about translation, we're talking about the structure of the data as well as the vocabularies within the data. So how we name things like heart attacks and ICD codes and stuff. All of that is translatable to other data sets across Australia, right? And there are data sets like the national data sets, the MADIP, not MADIP anymore, it's the NHDH and PLIDA data set for the ABS that have similar information that can all be translated as well. So what we're trying to do with the ARDEN project is to bring all of those researchers together across Australia so that we can all learn from each other and not replicate the translation. And if I can, at the end of 3 years, we get to that point where we have this really solid Australian, database of translations, then we've done our job So I think that data linkage in Western Australia can be very similar to a data linkage translation in South Australia, and we don't want to replicate the same work twice. We're too small, we haven't got enough time, we just need the evidence.
But I think the infrastructure components developed in both of those seem to be working in isolation.
I'd just like to say PHRN, the Population Health Evidence Network, Research Network, is a fellow NCRIS facility of the ARDC, and we work very closely with them. In fact, we've got a joint community of practice going with PHRN at the moment. And both Nicole and I worked on a data harmonisation project with them 3 years ago. So we work very closely with the PHRN, so we're aware of the work that they're doing. There's nothing in what we're doing that precludes data linkage. It's just not our focus at the moment. We're establishing the data sets. So it's certainly something that could be done in the future.
Okay, we have got to the end of time, but there is one question. Are people okay for one more question?
Steve McEachran, formerly Australian, now the UK Data Service. A lot of what you've talked about has been about we've got the data and now this mechanism for harmonising and working with it. A lot of the effort is getting to the point of being allowed to access the data. I was just interested to see whether you've done anything sort of around the approvals process to harmonise along those lines, so that once you've got the data sets that are there and they're fantastic, that I'm still, I've got not a 3-year wait before I'm allowed to use them.
Yeah.
Jodie, would you be able to say this one? Because you've got the most established data governance process in Queensland. Would you mind telling Steve what has been done in Queensland?
Well, I think at the moment we're still working on existing models for ethics and governance, right, with our research, but this is all part of the ARDEN process, and that project is, as part of it, is to try and work with, and we've got our OMOP PCG stakeholders from, like our data custodians, because as I say, we want to bring them along for the ride so that when we get to the end of this project, what does governance look like for projects that are using and tapping into this infrastructure? So I don't have an answer for you, but we're working on it. Yeah.
Just to finish that off, the ARDEN project itself, it's all about harmonisation. So not only are we harmonising the data, we want to harmonise the processes of accessing that data so that it's kind of a one-stop shop, or at least we uncover what the data processes are, and I think that's the first step. What do I need to do in South Australia to access those data for research compared to, Victoria? So if we can uncover that and make that visible, hopefully that will then progress all of this. So yeah, great point. All right, we have gone over time and I'm very sorry, but it's great discussion. So I just wanted to thank you very much and thank all of our presenters for talking today. And if you want to know any more about ARDEN, we have a website. I had it up on one of my slides, but Google it, ARDEN, and you will get it from the ARDC website. And please come and talk to me if you want to join the project. Excellent, thank you.